Of everybody's time, I'm going to kick things off. Welcome to all who have signed up for this. My name's Bill Black. For those of you who don't know me, I'm the president and COO of the Calgary Construction Association. Dan Hansen from Concrete Alberta also participated in helping put this together. It's really a continuation of work that we started along with a number of industry leaders at the outset of the pandemic back last March, where we realized that the industry needed to respond and collaborate on safety protocols in order to manage through the COVID pandemic. And we produced some documentation that was subsequently updated. And it was the result of a lot of collaboration with industry players sharing their information and their efforts in the interests of everybody, so that as an industry, we could respond and ensure that the information was available to all, whether they had the resources internally or not. And as we've continued, this group still meets virtually every 2 weeks. We keep up to date with progress on sites and what we've learned, best practices, etc. And as we've entered the sort of vaccination cycle, we felt that as a continuation of the work that we started, that perhaps getting some more information and insight around the vaccinations to help industry stay informed and help leaders inform their teams and such. And Dan Hansen helped put this session together. Thank you to Dan from Concrete Alberta. And without any further ado, I'm going to hand it over to the real expert. And if you have questions, please use the Q&A portion to type in your questions, and we will endeavor to answer as much as we can. So thank you all, and I'm going to hand over to the expert.
Hi, thanks for helping organize this, Bill and Dan. So I'll put up a little slide deck. But as that's loading, I'm going to just introduce myself. So I'm Jia Hu. I was a medical officer of health from Calgary, in the Calgary zone with Alberta Health Services. But then I sort of left to help lead the provincial vaccine rollout. Grew up in Edmonton, but I'm in Calgary now, for what it's worth. And, I think that we are, just to give people like a macro picture, I think, of where we are, with this pandemic. I mean, it's been like a pretty bad, like brutal, what is it now, 16 months, I don't know, whatever. And I think that we're finally at the point where, number one, we have vaccines that work really well. And number two, we have a lot of them. And I think that, if we have uptake high enough, we can basically, I don't think we'll ever get rid of COVID, but like it won't really control our lives anymore the way it does still today. I think, a lot about the United States, the United Kingdom, two countries that have sort of been ahead of us, the vaccine rollout. And, both these countries had far bigger problems with that, like COVID outbreaks, like COVID situation than we did. And they have very, very, very few cases now. I mean, I think in any given day, Alberta has about as many cases as the United Kingdom as a whole. And it's a good time, I think, to sort of talk a bit about the vaccination piece, because we're fortunate, I think, that we have a key, unlocked to just get out of this thing entirely. I'm going to actually try to go through this relatively quickly, and so we have more time for questions and answers. But thank you all for your sort of participation. Just a bit of overview of who we are. So, 19 to 0, we're sort of a coalition of organizations across, health and public health and academia, but also a lot of businesses, a lot of, civil society, NGO partners. And, we sort of built this coalition because I think that sort of what put on my public health hat, we've sort of asked all Albertans, all Canadians, all of them to do something. And that something over the Christmas season was like not see your loved ones, which really sucks. And I think that now we're asking everybody to get vaccinated. It will not be mandatory from a sort of a government perspective. And, with that, I think engaging, communicating with, and educating as many people as possible is really, really critical and important. So as far as what 19-0 does, we do a bunch of stuff. And so like some big marketing campaigns, a bunch of data collection to inform our campaigns, quite a lot of work with healthcare workers. And then, I think maybe the most important thing we do is actually, go and educate the public about COVID, about vaccinations, right? In fact, support organizations or try to support organizations who want to do vaccine clinics and whatnot. And so, if there's any further questions about anything, please let me know, but I'll just dive right into the vaccine thing. These go out of date so quickly, but right now in Canada, about, half the country has received at least one dose of vaccine, which is great. We're actually soon to surpass the United States in how many people receive that first dose of vaccine. And that's because they do have a more hesitant population there. And, I think that when it comes to really understanding sort of what herd immunity is, which is sort of a term that's thrown around a lot, I think initially we were estimating maybe 70%, and that was based on sort of non-variant regular COVID, which is a bit less infectious than the variant. But, with the variants that are more infectious, and with the vaccine, they work pretty well against the variants. I think people like Anthony Fauci, the US, I don't even know how to describe him, COVID guy who knows a lot about COVID, we're all thinking it might be closer to 85%. Which is sort of beyond reach sort of any province right now in Canada. And, I think given that we need to still do more, it's sort of, we finally gotten the supply. Now we need to convince people to get in their arms, really. So I think when it comes to sort of the vaccines, and this is quite a dense slide, I think, and it's sort of meant to maybe be a reference, so feel free to share this. But, we broadly have two types of vaccines in the country. We have our mRNA vaccines. This is the Pfizer, the Moderna. And then we have our adenovirus vector vaccines, so Astrazeneca and the J&J vaccines. And, if I think about these two vaccine types, I broadly view the Pfizer and Moderna as the same. They're both about 95% effective at, preventing COVID, severe COVID, hospitalizations, ICUs, deaths, all that stuff, all that bad stuff. And that's really good, right? So, 95% efficacy is one of the highest efficacies we have for any vaccines. Probably one of our best vaccines is the measles vaccine, which is also about 95% effective. And, measles is a far more infectious actually than COVID is. Measles is the most infectious, contagious, whatever you want to say, virus disease in the world. And, we mostly don't have a whole lot of measles these days, because of high uptake of a very effective vaccine. Moving towards the Astrazeneca vaccine, when it comes to, severe COVID, it's not as good at preventing symptomatic COVID, which is like a cough or something. But when it comes to severe COVID, hospitalizations, those sorts of things, it's probably about 85 to 95% effective. So pretty close to the Pfizer and the Moderna mRNA vaccines, and the Johnson & Johnson is sort of the same. Now, what that basically means is that most of these vaccines are highly effective and work pretty darn well at keeping you safe from COVID. Now, when it comes to some of the safety stuff, I'll talk a bit about the sort of the clotting things after. But by and by, vaccines are super, super safe. When we sort of develop vaccines, the threshold for safety is so high because they're sort of one of the only medical products that everybody takes. The only other medical products that pretty much everybody takes is maybe Tylenol or Advil, the stuff you buy over the counter. But the sort of required threshold for safety of vaccines is much higher than for sort of any of the other drugs you probably, if any of you are on medications like diabetes medications or high blood pressure medications, things like that. The threshold for vaccines has to be safer because everybody, we expect everybody to get one of the vaccines. Now, in terms of what vaccines we're actually getting in Canada, as we look into the next month or so, the vast majority of vaccine will be the Pfizer vaccine. And that's, has something to do with sort of just supply, logistics and whatnot. Moderna, AstraZeneca, and J&J are sort of newer to the vaccine game. They're all very good companies, but, Pfizer's basically, managed to arrange it so, Canada's getting as much vaccine as sort of we thought we would back in November before the shortages we, sort of encountered in January and February and March. And that's great. So more and more, there'll be mostly Pfizer vaccine for the next couple of months, which is very good. And so key lesson from this slide, and take home, read it if you want, is that they're all very effective vaccines. Now, when it comes to effectiveness, I think people are often interested in if they're effective against, regular COVID, but also the variants, right? And so if you look at this table, we sort of have regular COVID, ancestral COVID, run-of-the-mill COVID. We have the UK variant, South Africa variant, Brazil variant, and then the India variant. By and by, the vast majority of our variant cases, probably most of our cases actually, are now the UK variant. And when I say vast majority, 95% plus of our cases are the UK variant, of our variant cases, UK variant. And all the vaccines work pretty much the same against the UK variant as they do against regular COVID, which is great. The other vaccine, the other sort of variants, we know a bit less about how well the vaccines work, but we're getting sort of more and more of this data now. But as far as the South Africa one goes, the mRNA vaccines work quite well. Astrazeneca, not so well. Fortunately, we don't have a lot of the South Africa variant. And the same broadly could be said of the Brazil variant, but we know less about that, and the India variant, which we also know less about. And so I think that there has been a lot of concern around, just variants in general, which tend to be, one, more infectious, so easier to get, and two, can cause more severe disease, which is not good. But the good news is for the variant that we have, the vaccines work very well against that. This is now going to shift more into some of the safety issues. But sort of, as I mentioned before, the general bar for vaccine safety has to be extremely high, just again, because they give it to everybody. I think when, apart from this VIT thing, which I'll talk about, the only side effect really of a vaccine that might be seen as sort of bad is this anaphylaxis that can occur. And that's very, very, very rare, like 1 in, 4 in a million, perhaps. And sort of on par with the other vaccines you might get, the ones your kids get when they're, in their infancy or at the school age, and, like the flu vaccine. And so that profile is the same. There has been a lot of news around this sort of unique, weird clotting thing that occurs with the AstraZeneca and the J&J vaccines. And we've given it a very long name in medicine. I don't know who picks these names, but this vaccine-induced immune thrombotic thrombocytopenia, or VIT. And really what VIT is it causes sort of a type of clotting that is different than the clotting that COVID causes. And, the reason this is important is that it is important to recognize that if you get COVID, the chances of getting a blood clot are extremely high. So about 10 to 40% of people who are in the hospital have clot in their leg, clot in their lungs from COVID itself. And your likelihood of getting a clot from COVID is like astronomically higher than your chances of getting a clot sort of from one of the vaccines. Now, how common is clotting from one of the vaccines, the AstraZeneca and the J&J? It's about 1 in 100,000, which is, sort of like parlay that into, you're about as likely to die in a car accident this year. I mean, it's not a risk that we normally think about or entertain, but it is extremely rare. While VIT is quite serious, actually, I think that, when it's caught early, it is very treatable. And, I think as we sort of become more aware of it, we're identifying it earlier. We're able to treat it earlier. But I think that the key message really around the vaccine safety piece is that vaccines are super bloody safe. I think that when it comes to people like myself, the public health people, infectious disease people, the people who sort of make recommendations around the use of vaccines, for us to recommend anything, the benefits of taking the vaccine must far, far, far outweigh the risks. Just to give you an example of sort of what that looks like, a couple of months ago, Alberta Health Ministry did a little analysis. And, if you are in your 50s, your chances of, getting COVID and dying from COVID were about 50 times higher. Not just like dying COVID if you got it, but just getting it, period, and then dying from it, than of a sort of a VIT event occurring. And I think that while it's great that we're beginning to sort of come out of our third wave, our SUs are pretty stretched still. The risk of getting COVID is probably higher in Alberta than almost every place in the world, actually. Where we have the most cases per capita in Canada, and Canada some of the highest cases per capita in the world. But, if I look to the United States or the UK or some of these places that had far higher caseloads actually than we ever did, they don't have a whole lot of cases anymore. And a lot of that has been because they've been able to sort of immunize more of their people more quickly. Although if we, we'll have more than enough supply to sort of immunize everybody in the country by September. And, we're quite likely actually to surpass the United States in how many people receive at least a first dose in about a week, I think, because they do have more of an issue with hesitancy. So I think when it comes sort of to the safety piece, I think they're very safe. And normally when I think about how to consider, should you get a vaccine or should you not, it's important to always, just like with everything in life, like what are the pros, what are the cons? And in the midst of a third wave that's still pretty bad, the benefits of getting that vaccine become extremely high. Every day we learn more about the vaccines, basically, because there's more studies happening in different populations. And, quite recently, we recommended the use of the Pfizer vaccine in kids 12 and up based on some, the study that they ran. It's very safe, it's very effective. And, more and more we're going to see, well, right now there's lots of studies with Pfizer and like Moderna and other vaccines in kids 6 months and up, actually. And so I think that, when it comes to vaccinating your children, I think the Pfizer vaccine right now known to be very good in 12 and up. By the time the summer rolls around, I think we'll have data on, the vaccines and their efficacy and safety in kids 6 months and up. And I think that if we ever, want to see a sort of a non-disrupted school year, and it could be as early as the next school year, getting as many kids immunized as possible will be really critical. And, talking about herd immunity, I don't think it's really possible to achieve herd immunity, I think, without immunizing kids. It's a, there's a lot of kids, basically. I think that given that, we're about to see more of the vaccine available, I think, in more sort of like pediatric age ranges. If you have any specific questions about that, just let me know. Oh wow, this is here another sort of thing that has been in the news a lot has been around sort of the extended dose intervals. Like, why are we not saying that we should stick to the clinical trials which show vaccines given between 3 or 4 weeks between the two doses? And I think that, just to help you understand like how we make our decisions, right? So the first sort of sets of data we got on the vaccines at a large scale was some of those randomized controlled trials, where you give half the population a vaccine, half the population like a placebo vaccine that doesn't actually have vaccine in it. And you see how well they protect people, right? And those are some of the biggest trials that have ever been run with, like 40, 50, 60,000 people in each study. But that's still a very, very small fraction of, the data we can get when it comes to what I call real world evidence. And what that is, Israel, for example, is one of the first countries to start immunizing their population en masse. And then you had the US, then you had the UK sort of going in parallel. And we basically look at these countries where, that's not like tens of thousands, we're talking tens to hundreds of millions of people have been immunized. And we just see, how well does that one dose protect you? Like how well does that second dose protect you in the real world? And, right now, all of the vaccines we have available generally, offer about 80% protection after that first dose, which is really good. Of course, we always want everybody to get that second dose. And the reason why we have been sort of recommending a first dose extension was because we've had supply issues. And I, often like to say that, if I, had 2 vaccines, I'd probably give one to each of my parents. So they could each have 80% protection, then for, one of them to have 95% protection, for the other to have 0% protection. I think that as our supply increases, I suspect many people will not have to wait 4 months, to be honest, for that second dose. We'll see how the supply goes, but, there's a ton of it coming in. But I think it's important to know that we don't sort of just make this stuff up. We do base this on large swaths of data from, studies of tens of millions of people. I think that, I may just actually stop here and see if, I like this sort of Q&A more, but yeah, I'll pause and see if people have any questions actually. So I'll stop sharing and thank you for your attention.
Now, there are some questions in the Q&A. I don't know if you want to pull them up or do you want me to read them out loud to you?
Oh, no, I see them. Yeah, from Brian, we see, given the statistics regarding the variants, does Ja believe we will require a second round of vaccinations beyond a second dose? Yeah, so I think that like this is around the people need boosters or not. And I think the biggest driver of whether or not we need boosters is going to be how long the vaccine protects you for. So we know that when it comes to natural infection, because you get some immunity from that, it does tend to wane like at the 6 to 12 month mark. That's one thing we know. I mean, the second thing we know is that vaccines actually tend to give better protection than natural infection. You stimulate your immune response a bit better. But given the fact that, your natural immunity only lasts for 6 to 12 months, which is not particularly long, like, with measles, if you get it infected, you're basically protected for life. I think, well, we can't say for certain. I suspect we will need boosters. And a lot of other people who are smarter than me also think that. In terms of sort of complications around receiving a second round of vaccinations, I don't think we know the answer to that yet, but I think that there's no reason to think that if you're sort of first 2 doses, like your initial series is safe, that your sort of booster series sort of wouldn't be safe. But be assured that like as we start requiring boosters, there'll be a bajillion studies looking at sort of just how safe and effective boosters are and how often we need them. All right, so question from Paul. It seems the US seems to have a lower incidence rate at the moment and their health resources aren't as strained as ours, and that can be attributed to the number of people who received 2 doses. Why aren't we following that model? I would say that the bulk of it is a great question. I think that, the biggest driver of the US does indeed have a lower incidence rate. And I don't think it's like the 2 doses that's necessarily helping them. It's like the speed at which they had at least some people with 1 dose. So the way these vaccines work is that you don't like get protection the same day you get the vaccine. With a 1 dose series, you need to wait, like with the first dose, 2 weeks for some protection, 4 weeks for like full protection. With the 2 dose thing, you get your full protection after, like a week or 2 after that second dose. And if I think about how many people we've immunized, let's just say over the last month, and so thinking about it, go back a month, and that's the sort of number of people that are protected as of today. And like that number from a month ago, I don't know, I'd imagine was in like the 20s or like the low 30s, and now we're at over 50%. Whereas the US sort of like got rolling, they're basically like a couple months ahead of us. There are sort of other factors that play into this, like how open you are and whatnot. But I think a lot of what happened with the US and the UK and Israel they just did more vaccine quicker. And it does take some time for that vaccine to kick into effect, 2 to 4 weeks. And, in sort of pandemic terms, 2 to 4 weeks can be a very, very long time. Cool. Great. Lots of questions. Yes, perfect. Mixing vaccines. This is great. So there are a number of big studies looking at mixing vaccines happening right now. Actually, I think this morning, one of those studies, which is based out of Spain, reported some of the results in a press release. I did try to read it, but it was in Spanish. But I don't really read Spanish. But the gist of it is when we look at some of those mixing studies, which is like generally AZ, Pfizer, AZ, Moderna, AZ, like, things like that. There's a few configurations. Number one, I think one study showed that the first thing you can figure out is just the side effects, because once you jab somebody, side effects within a day or 2 tend to be very mild. Well, they tend to self-resolve. And they're mild, but they can pretty much take you out. Like this is like fever, headache, chills, like pretty common stuff, which is your immune system working. And the studies did show that there was an increase in some of those temporary side effects like fever, headache, fatigue, those sorts of things. But they went away in a couple of days, which is great. What was reported today actually was the immune response. And again, I haven't seen the paper, it's not out yet. It's just sort of a little press release. But they said that in people who got the first dose of Astrazeneca, getting boosted by a Pfizer led to quite a significant boost in sort of like your immune response, which is your antibody counts, and that's made by your B cells and your T cells as well. And so I think that, we're still waiting for like the the best piece of data from those studies, which is like, how well do these things work in the real world? And so I think that once that comes out, we will have a better sense of whether or not we recommend mixing or don't recommend mixing. The biggest driver, I think, for mixing actually has been from sort of some of these supply issues. A number of European countries that, Europe is primarily like by AZ actually, because, well, AstraZeneca is based out of the UK with a big presence in Germany. And a lot of those countries had to recommend mixing earlier because they just ran out of AstraZeneca, because AstraZeneca sort of, the best way to describe it is it's the most sort of logistically easy vaccine in many ways. And that's the vaccine that's sort of going to hopefully end COVID for the world. And so I think that we will know soon enough, actually, what the recommendation is around mixing versus not mixing versus like choice versus, no. And I think a number of like a province now, so you can sort of choose your second dose. Of course, all this is contingent on supply, but I'm pretty confident that the mixing should be, well, safe for sure, yes, and hopefully very efficacious. Cool. From anonymous attendee, what about the potential long-term effects from a vaccine that doesn't have data from long-term testing? What could be the potential impact toward children 20 years from now? Yeah, that's another really, really good question. I think that, when it comes to the development of these vaccines, well, here, I'll say this first of all. You're right. Like in a way, like we haven't had the vaccine for that long, so we don't necessarily know what's going to happen. But I think what gives me confidence sort of in these vaccines is, like, number one is that, the way the vaccines work is that like you have a few, like you have, let's say for an mRNA vaccine, right? You have your mRNA, and then you have a bunch of other stuff in the vaccine, like there's some liquid in it and some other ingredients you can look up. And a lot of those ingredients, or basically all of those ingredients, have been used in other vaccines, probably administered to billions of people. So we do have sort of long-term data on like those pieces of the vaccine. When it comes to sort of like, could the vaccines have long-term side effects? I think the likelihood is very low based on just how these vaccines work. Again, I'll use the mRNA as an example, right? So the mRNA vaccine, like all vaccines basically go into your body, and they're meant to like elicit an immune response by producing spike protein, which is coronavirus is these spike proteins on it that let it attach to the human cell. And so you basically produce a bunch of spike proteins, and then your immune system recognizes it. And then when you see, you can't get infected by these spike proteins, it's not a whole virus, it's, but what happens is that your body recognizes it. So when you see coronavirus again, like, or real coronavirus, like it can just like jump on it and like kill it really quickly. Now, the mRNA itself is like, like we've talked about, like this stuff has to be kept in these like -60-degree fridges, because, it's super unstable, like, and it just gets eaten up by your sort of like body's intrinsic processes very quickly. And, at any given time, your body has a ton of mRNA. The mRNA is the stuff that is like the conduit between your DNA, which encodes your entire, genetic sequence, and just the production of the proteins that make your body. And, there's no way for the mRNA to like integrate into your DNA. There's no way for, the adenovirus vector vaccines to do the same, either. And so I think that with like that understanding, it is very implausible to think that we will have these crazy long-term side effects. We have a lot of experience with vaccines in general, right? I think the second piece, as you sort of consider this, is always the benefits versus the risks, right? And, I think that we're on a pretty good path, I think, getting people vaccinated, but there are a lot of people who don't want to get vaccinated. And I think that there's risks not being vaccinated sort of at an individual level and a societal level. I mean, with kids, they tend to do pretty well with COVID. Generally, you can die from it as a child, but it's very unlikely. There's that inflammatory syndrome that's pretty severe, but pretty treatable. But then you have this whole long hauler thing that I think is like really troubling to younger people, because it affects many, many people, estimates between, we'll say like 10 to 50% of the population, that we don't quite understand it very well yet. And what long hauler is, because coronavirus can sort of affect like every organ in your body. You have these people who have like fatigue that can't go away. They have like shortness of breath that won't go away. They have lots of other unusual symptoms. And I think there's a real sort of harm to having that. And that's why a lot of younger people, like, if they're not worried about getting COVID or dying from COVID, I say, you probably don't want like long lasting fatigue and shortness of breath that you can't sort of fix. On a more societal level, I mean, like the last year that we've lived through has been really crappy. Like it's been crappy, like, and I don't even know if I need to say this, on the one level, because like, lots of people have died from COVID. And on the other level, there's been these lockdowns, and I generally describe lockdowns as like the second worst thing that like we can impose upon ourselves. And the first being like letting your system be overrun with COVID, like Northern Italy was, or New York was earlier in the pandemic. And, I think about like just the sort of mental health implications of that, just the, the learning disruptions of that, like all the stuff that sort of like messed up our society, then, there's many, many reasons I think to be immunized, and the benefits coming and accruing sort of both individually to yourself, to your own kids, as well as to, everything like that's been happening. But that's a great question. Many drugs go through extensive use of testing before they are approved and made available to the general population. Okay, so yes, I'll explain this. So the way, first of all, the mRNA vaccine, like that technology has been researched for about 30 years, I think, right? So we can just whip this up immediately. Adenovirus vector vaccines, the adenovirus platform has been used in like gene therapy and other like uses before this. And so I'm saying, first of all, we're not necessarily starting from scratch. When it comes to like how you do a series of vaccine studies, so you tend to have 3 phases, right? In the first phase, you give it to like healthy adults to make sure, it's safe in healthy adults. And those studies take about a month or 2. And so we did those regular time frame. The second phase, or phase 2 vaccine studies, look at the immune response in sort of a range of people, healthy, old, whatever. And, those again, because you're just looking at the immune response like 4 weeks, 8 weeks out, are done in, well, generally 8 weeks. And so we did those, and they were sort of on the regular sort of time frame for vaccines. And then the third phase, which is the big one, is the clinical trials that we do. And this is where you recruit tens of thousands of people, half of them get the vaccine and half of them do not get the vaccine. And with the clinical trials, I think that, this is where a normal vaccine clinical trial lasts for about 2 years. So with these vaccines, we were approving them with sort of data at the 3-month mark. And, I think that the reason that we sort of did that was because, the benefits of, we just really needed vaccine to, stop the millions of people from dying from COVID. Now, I think that, and that part is true. Most vaccine trials last 2 years. We approved after 3 months. The one thing I think that we sort of have hopefully in our back pocket is that like nothing has been as studied as much as, like nothing ever basically has been studied as much as coronavirus vaccines, right? So you think about like how many, like, yes, the phase 3s were like, they were approved off shorter periods of data. On the other hand, you sort of had hundreds of millions of people sort of getting the vaccine, and in all those people, it has generally been safe. And I think that, when it comes to safety, like it's like the regulators are like pretty friggin' obsessed with it, right? Like, and by that, I mean, I think there's been a ton of confusion around, the Astrazeneca vaccine because, initially Canada suspended it because of this VIP risk. And that risk is really, 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 really low, right? But like as soon as they see any signal, right, just with the US too, right, with the J&J vaccine, they suspended that after giving 7 million doses and seeing 5 cases of this clotting event. And, when you're talking about a 1 in a million risk, like you're, definitely, I don't know how to just like, your risk of that is about as likely as getting hit by lightning, which is not, again, normally a risk that we are worried about in day-to-day life. But I think it's all we really is about sort of the benefits versus the risks, but no safety steps were skipped at all. And we are really, really concerned with sort of the safety profile. And as soon as we detect anything, like clearly, we suspend, we shut it down, we investigate, which I mean, I think can be very confusing to people, but that does show sort of just how much we respect sort of like the safety piece. Why are we penalizing people with quarantine who want to go to US border down the window just for, I don't think we're doing that anymore. I think that policy changed like 2 days ago. Yeah, I think so. Anyways, yeah, I mean, I'll say that like when it comes to quarantine policy, and this is made at a federal level, I think that Canada's used a one size fits all approach, which is if you're coming from anywhere outside of Canada, you quarantine for 14 days. I don't think that necessarily makes the most public health sense. If you're coming from China, which basically hasn't really had any cases of COVID in a year, they've managed it very well. I don't think it really makes sense for you to need to quarantine. Like you're increasing your own risk especially if you come to Alberta or Ontario these days. But I think that, this is sort of, I guess, what the feds have chosen to do to, I don't know, be consistent. But I do think that you can now just drive to the US, get vaccinated and come back without being quarantined. It's an interesting thing you raise actually about the United States here, because the US is like way more supply than there is demand right now. And, that's a problem. Well, it's, good for us who can drive down to the US. But, in the medium to long run, or the short to medium term, what that will basically mean is that the US will have a much more difficult time actually suppressing COVID compared to a country like Canada, where, we're not going to hit herd immunity either at current rates. We'll do a bit better than the United States. I think, which again, really sort of, they were first out of the gate, which is great. But I think that we're closer to the finish line than they are. It's a lot easier for us to get to the finish line than them. I think the risk of complacency that we have to really. Okay, I should double check that. Thank you. I will double check that for you. Thank you. Well, you just turn on your microphone too. I think the risk is much higher if we insist they'll wait another 2 months for their second shot. Yeah, I mean, I think that like we are trying to get as many people one dose as possible. And I think that's because right now still only about half of Albertans have gotten their first shot. I think that as soon as we can open it up to of course I want everybody to get their second shot as soon as possible, but there is sort of like, a supply constraint issue. And the other thing I was going to say is that, I think all the questions that you sort of asked in the chat, they're all really, really, really good ones. And yeah, this is like a small enough group where I'll just give you my cell phone number in case you have any follow-up questions. But I think that, what I never want to do is there's a lot of this judginess happening around vaccines, which I don't like, and by that, I mean, I think that for what it's worth, I think there's this shame or you're stupid if you don't want to get a vaccine. And I think that's not at all the case. I think people have lots of very reasonable questions about this fairly important health decision. And so, I just want to say that please don't feel judged by anybody. And if you do, they're wrong, not you. And then we'll double check on the quarantine thing. In fact, I'll text somebody from the Public Health Agency of Canada right now.
Jean, when you're done texting there is one other question in the chat I can read out to you.
Sure, you can read it out.
Okay, and you may have touched on this, but maybe I'm not sure if it was clearly answered, so I thought I'd read it out. Yeah. It's from Kate. Considering there appears to be a small amount of AstraZeneca left, is it safe to have a second vaccine of a different variety?
Yeah, so I think I talked too fast, but I mean, I think right now the studies around mixing are beginning to come out. So there's the one study showing that you had worse short-term side effects, like the fever, headache, chills type thing that goes away within a week. And that came out 5 days ago. I'd want to wait to actually see the study as opposed to see a press release of the study. But I think I would sort of expect the side effects potentially to be more if you actually are generating immune response. But, I think by the time you're up for your second dose, we'll definitely have that information. I suspect it will be, but let's wait to see what the studies show. I feel like I say that a lot because there's always more stuff to learn about the vaccines and the virus. Just for a vaccine appointment. Okay, I asked my Public Health Agency of Canada contact. Cool. Anything else, people?
I actually had one question.
Perfect.
I noticed a construction firm in Eastern Canada had collaborated with some other trade contractor organizations and had put together what they were calling a pop-up vaccination opportunity as a way to sort of increase the accessibility to construction employees and you know, as part of the industry's response. Is that controlled? Is the ability to do that controlled by the province?
Yep.
Does that require and is there any possibility that, subject to supply, that similar moves could be done in Alberta, or is that unlikely?
No, I mean, that's a great question. I've talked to Dan and the other part a lot about this. Basically right now, and I do a lot of work with government, and so that is a decision that is ultimately made by cabinet, but like mostly driven by the bureaucracies, the deputy minister. And like, I've been sort of angling for these pop-ups on sites forever. Right now, basically everybody in the province saying, like, Nancy's trying to get them. AHS had a big review saying we should have them. Like community organizations, like we have you might call a very broad-based lobbying coalition trying to get these things. And I believe that actually, you know, cabinet was meant to make some decisions around this sometime this week. I mean, to date, they sort of said no, but I mean, I think they're a no-brainer, you know, and so stay tuned, I guess. I mean, I like, it's like, I'd say that, you know, throw your hat into the advocacy piece, but like we have literally like got like, I don't know who isn't advocating for this right now, to be honest. And, you know, like, I think they make total sense. And, you know, when the time comes and we're allowed to have them, I bet we will be, you know, when, you know, you need, like, if you need a hand setting it up, just give me a call and we'll help them get set up. Because I sort of know with people who have sort of shift work and whatnot, it can be hard to get to the vaccine clinics. You know, we want to make it as easy as possible for people.
Yeah, no, appreciate that. It's just, you know, we're all trying to,
I know,
what we can to at least, you know, make it accessible. And of course, our industry, the demographic being younger, that you know, we're seeing more recently, the younger age groups were contracting and seem to be more at risk. The demographic is our field, our people that work in the field on the job site. So, you know, there's definitely our industry is very in tune with the need to help these things happen. So we will stay tuned, and if needs be, we will add our voice to the ruckus that seems to already be in play.
Yeah. You know, I think that what I'd say is, like, let's see what happens this week. Like this, you know, there was a Gold Mill article published basically saying AHS's like highest technical body recommended these things, and AHS almost never like recommends something that the Ministry of Health doesn't want. Like, that is highly unusual. And so I think if we don't hear some good news by the end of this week or next week, I might, you know, we might have to, I don't know, try new tactics. Don't tell Dina I said that. She get mad at me. Oh, Frederick
Vine. Fred, do you have a comment?
I think the only comment that I would have is, you know, Alberta Construction Association did send off a letter to the government asking for consideration of the vaccine rollout to the construction industry. We have not got any response. But right after we sent that letter, they opened up the vaccine age limits to all the way down to people age 12 and above. So essentially all construction workers are eligible now, which was our initial request.
Yeah, no, that was, I'm really glad it's open to everybody. I think not being ignored by health is very common. it's pretty interesting, this pandemic. I think they have limited bandwidth in getting a lot of requests, but again, I think that, if we haven't heard positive news by, let's say, this week or next week, because I know this is being deliberated at cabinet. I think I'm pretty sure, I'm almost certain it's being deliberated at cabinet this week. We'll report back and we'll just re-advocate, re-lobby. So.
Sure. Just if everybody's aware, if anybody has any specific comments or questions, you can unmute and speak live rather than type. Does anybody have anything else? Any questions, any comments, etc.? I'm not seeing anybody unmuting. Certainly, once again, thank you to folks who signed up for this. As was noted, we have recorded this session and we will make a recording available so that you can distribute this to others in your network or your organization. Really appreciate Dan Hansen's help, Dan from Concrete Alberta. Thank you to our fellow construction associations in the province who have also distributed the invitation, and thank you, Doctor, for sharing the information. And as Matt already commented, the sort of candid nature of your feedback, it's refreshing. We can all feel a little over communicated to through PR filters, and so having a human means of getting questions answered and discussion, I think, is refreshing after a lot of arm's length communication. And I definitely think that we need more of these kind of conversations, and really appreciate your availability. Brian Han just commented in the Q&A, Brian Han from Build, extremely informative webinar. Build also we were working alongside Build so that the residential and commercial sector was doing its best to keep informed, and we have continued that connection. And who knows, maybe we will need to reschedule another one of these down the road here. But if there are no further comments or questions, on behalf of Calgary Construction Association, ACA, ECA, Lloydminster, and all who are here from industry and otherwise, thank you for attending. Thank you for your interest and commitment to safety. As an industry, it's part of our trademark that we care about safety, and COVID really just is another aspect that we've had to evolve our approaches to be able to accommodate and protect our people and the public. So thank you for contributing to our knowledge and our ability to do so. And we look forward to the other end of this and looking back at COVID as opposed to wondering when it's going to end. But you've helped us take steps in that direction. So thank you.
Okay, you're welcome. Have a happy Thursday. Thanks for hosting.
Yes. Stay safe and well, everybody, and have a great long weekend, even though the weather's not going to help, but whatever. Deal with it. We will see you all soon. Thanks again, all. Bye-bye.